Hey team, hope you're all well. Thought I'll share a special case to you guys. So I did a conference presentation in 2018 in New Zealand. I was selected as one of the cases for one of our clinical studies at University of Otago. So I thought I'll just share it with you guys and get a different perspective. So the case was about the rehabilitation of a complete edentulous patient with a non-attached mandibular mucosa and a flabby maxillary ridge, and full consent was given from the patient to use her photos. So our team consisted of our clinical supervisors, so John Arts, Paul Piers, myself, and my clinical partner, Jivan. So a little bit of a background of a patient. Mrs. I was a 72 years old patient who was an ex-teacher. A really lovely patient, sophisticated, and came to New Zealand a little while back from Romania. Beautiful country. So her primary reason was that when she came in, she just wanted a stable mandibular denture because she had no ridge stability. So she wanted to obtain her stability and retention and support upon masticatory function. So her main concern was food traps, being trapped, and obviously stability of the denture when in function. There was also a cheek biting due to wide maxillary arch. As we can see, she does have a resolved mandibular ridge, a little bit of cheek biting. So moving on to the history and examination. Based on her medical history, her condition, she had gastropharyngeal reflux disease, or the GERD, also known as acid reflux buildup of the acid. Basically, this resulted in taste buds being affected in the back of her mouth, where the sphincters were closed and acid was being built up. So even the color of the denture was discolored over time, which wasn't good for her as well. Based on her medication, there was omeprazole being taken daily to reduce this effect of acid reflux, which acted as a proton inhibitor, blocking the release of stomach acid in her body. In longer term, it wouldn't obviously be beneficial for her due to the buildup of acid, and obviously it's not beneficial in terms of protons being built up, and longer term causes a bit of a dry mouth, the side effect of one of the medication. Based on her other history and examination, her dental history, she had a full upper denture made in 2014, but obviously by February 2018, her maxillary denture had broken. Her mandibular denture was quite unstable and started new dentures in March 2018. So her attitude and expectation, she was obviously genuine, patient, very happy, very kind, and didn't really have a high expectation because her main concern was to gain her stability and obviously eating upon function. So she did have a little bit of a moral consideration on her aesthetics, as she wanted to have a similar aesthetic line to her previous denture. Her extra oral examination, as we can see from the photos, her right eye was slightly higher, a little bit of a freckled face, her lips was slightly sagged down, so obviously her nose was quite symmetrical, and her depressor angular oris was reduced due to the loss of muscle tone, and this resulted in reduced OBD, which was the loss of lip support, so we had to increase the OBD in the freeway space, and there was no clocking of the TMJ joint, so there was no abnormal mods that we detected. So our RVD of the L denture was measured as 55 millimeters and RVD was 58 by Willis gauge with a freeway space of 3 millimeters. Her intraoral examination, based on her maxilla, she had a Ridge ACB classification 1, good labial Freeman, and flabby incisor papilla and maxillary tuberosity. So we had to use a selective pressure technique, both the mucostatic and mucocompressive techniques. So based on her mandibular ridge, she had ACB classification 2 resorb ridge, type C ACB classification muscle attachment, so basically no attachments in her lower, and class 3 maxillomandibular jaw relationship. So obviously we can tell that was a little bit of a tricky case, especially with her lower. She had very flat ridge and she wanted to basically optimize her stability. So moving on to the mucosa of the mucosal attachment, based on the tissue, as soon as we pull out her orbicularis oris, we can see that the mandibular ridge is being exposed and there's no attachment, so it's quite easy to compress out, and so meaning that when the denture is in stable position, it will still be quite unstable, so we had to rehab it by using a neutral zone selective impression technique. Moving on to her intraoral examination. Based on her features, she had quite a healthy tongue, normal looking tongue with good texture and obviously the color red. She did have a well attached lingual frenum and prominent sublingual conical. And of course, a good salivary flow rates. That's quite important with the retention, and obviously helps with a lot of digestion, with the salivary content being in the enzymatic activities. So her diagnosis and treatment, we had to obviously have this quite in detail from the start. So patient expectation was stated from the start of the treatment. So a few problems which we had to deal was resorb mandibular ridge with limited stability due to disturbance forces and unstable mucosa. This was regained through neutral zone technique due to instability of mandibular ridge. It was flabby maxillary and tuberosity and incisive papilla, meaning that we had to use a selective impression technique and combination of unattached mucosa with strong lip muscle causing unstable mandibular ridge. So initially at this stage, bilateral balance was selected. However, as the case progressed, we had to change it to lingualized occlusion for better stability and obviously patient comfort, better and centric occlusion position. And a little bit of cheek biting, we had to reduce this by minimizing the maxillary arc. So we took primary impression with alginate impression material. These are the primary cast. We can see not a lot have been captured, and quite unstable ridge in terms of her orbicularis muscle, and less attached on the mucosa. So moving on to maxillary custom tray, we gave hydraulic holes just to relieve some pressure, especially in the maxillary tuberosity and near the rigor region. So the first key learning outcomes was the selective impression technique. This is quite important. Key issue was obviously the flabby maxillary tuberosity and incisive papilla. We initially took a light body impression material, then cut these areas that had high impact pressure, meaning there was mucostatic, and then we compressed it with mucocompressive impression technique. This can obviously be used with selective impression technique of heavy or medium body. Medium body is preferable as it captures quite the periphery attachments. So Boscher 1951 highlights the concept of selection impression technique, where certain pressure is selectively applied in areas of flabby tissue, minimizing the displacement of flabby tissue for an accurate impression. And Boscher in 1951 highlighted the importance of space design relief, stating that the stress-bearing area for flabby tissue is relieved. This is cut to low viscosity wash impression material to minimize pressure, giving an accurate impression. Just have a look at the diagram. Alright, moving on, we use the mandibular custom tray. As we can see, the custom tray is a slightly different design, quite thin on top of the ridge, allows enough space for occlusal muscle, the tongue, and right at the front of the ridge, where the buccinator muscle and the cheek muscle lies. We then use the neutral zone podiatrics technique, where initially heavy body was used, then medium body. Heavy body just to bring out the lips and capture as much as we can, and then wash, capturing the rest. So this was captured in functional impression, where the orbicularis muscle was captured and the buccinator muscle. Then you put a little bit of Vaseline around the front area, take a podiatrics of the front concept, and then this enables both the buccinator muscle area, orbicularis muscle area to be captured. And of course you can put one on the tongue space. Yeah, so you can see it's quite well captured, heavier than my body all around. So our key learning outcome for Nutrizone, there was quite a few. So stability of the lower was our main concern. So Nutrizone impression was taken where a patient was smiling and moving jewels left and right simultaneously. We use medium body to push lip out of residual ridge, followed by wash impression. The second mandibular cast keyhole grooves was cut for silicone to be placed. So just have a look at the photos. A little bit of water. Alright. Yeah. So we then introduce the concept of Nutrizone, where we capture the space this occupied where the natural teeth position was. So the forces of the tongue pressing outwards are neutralized by the forces of the cheeks and lips pressing inwards. Lynch in 2006 stated the importance of low viscous wash impression material to be used due to flowability of the material, allowing it to capture orbicularis muscle and the buccinator muscle during functional movement, such as speech, smiling, and eccentric movements. There's a Nutrizone area. There's a podiatrics, buccinator muscle, orbicularis muscle. Obviously, that's quite thick. So the impression taken, then silicon matrix or the frontal aspect where orbicularis muscle is captured. And the lateral, which we stated, was the cheeks, maxillary muscle. So just the parimetrics, you just put a bit of an index, and you can put exactly where the maxillary and the lip muscle is, and you just fly it around, captures it precisely, and obviously uses it to for the optimal stability of the ridge. Moving on, and the secondary master cast was done, quite accurate compared to the first, and obviously residual ridge captured quite nicely, and it is obviously quite resorbed, and grooves were cut indexes just for the cutting matrix to be placed, and this is about 2 millimeters in front of the vibrating line, the palatal further. So a little bit of comparison between primary and secondary. Primary not too much captured. Secondary, all the ridge captured quite nicely. And obviously the cut, the putty key matrices. These are the bite blocks. Maxillary and mandibular, about 18 and about 2 mils in height. And make sure it's stable and cuts all the way around the ridge. Near the sulcus line, 2 millimeters. So we took the bite registration, earbone, and obviously the teeth selection, where she decided to do A2, similar to her old dentures. We used the Frankfurt campus plane, parallel to her ear to the nose. Always goes from the bottom of the nose to the bottom of the chin, and obviously the ear belt phase belt registration, which registers exactly how it is in the mouth to the articulator. She had a LVD of 60 and a LVD of 63. We optimized her freeway space by about 3 millimeters, which is optimal. Moving on to the first try-on. Everything was good until we tried in the mouth, which was first and second wax try-on. So initially the first try-on, the bite wasn't correct in the mouth. So we set it up in balance occlusion. Then the second time we changed it to a lingual occlusal scheme just so she can have more movement and centric. And then she wanted a bit of a maxillary occlusal plane 1 to 2 millimeters above, just so she shows a little bit of a less smile. And obviously we moved the posteriors up a little bit as the first try-on was a little bit reduced in height. So final test set up, patient was happy, bite was correct, and obviously less wax up, quite thick around the occipitalis oris area and the maxillary area, just because it is the neutral zone technique. And yeah, we did reduce the area at the back with one less premolar just to minimize her from cheek biting. So another key outcome, which was the concept of lingualized occlusal scheme. So in order to maintain the retention, stability, and support for the longevity of the dentures, you obviously have to take into consideration all these factors, and especially with her case where she did have a lot of unstable ridge. So initially we tried on the balanced occlusal scheme, however it became apparent that Masai didn't have a functional or favorable anatomical landmarks because she had no muscle attachments, especially for her lower mandibular ridge. This meant that bilateral balance was not selected and hence lingualized occlusal scheme was used. Saab in 1997 highlights the importance of intraoral examination and the direct influence on the treatment planning. Parr then in 1996 highlighted that patients with ridges are recommended to have lingualized occlusal scheme. So obviously in terms of her function and stability, lingualized is optimal as the maxillary palatal cusp contact the mandibular central fossa without buccal context. It also has better patient tolerance and comfort due to increased freedom of movement, especially in symmetric occlusion, because it's not fixed and obviously has a little bit of a freeway space between 1 millimeter between the palatal and the buccal cusp of the lower. So moving on, denture insertion. This was the final case. Bite, everything was quite nice. Patient was happy. Final denture in different positions. So this is before and after. We can see it was quite sagged in, lower ridge. She wasn't as happy. Now she's smiling finally. We did increase her RBD 3 to 4 millimeters, and you can see massive differences in her orbicularis muscle, and her dimension increased a little bit compared to that. So 3 to 4 millimeter freeway space was minimal, optimal based on her case. Completed denture before and after. Obviously before she didn't have a neutral zone technique. Neutral zone means it is less obviously aesthetic wise in terms of the contouring of the denture, because less contour means more hygienic and easier for the patient to clean it. And before she had cheek biting, increased teeth, so we had to reduce it in size. Upon the frontal labial profile was over contoured, and we just reduced it in size. And labial frenums wasn't incorporated. Very overextended, and we underextended it so to the exact measurement. And there was quite a bit of foot traps in her old one, but the other one, the new one, she was quite happy. Obviously, we can see orbicularis and the buccinator muscle and the cheek area extended just for maximum stability and retention of the denture. So moving on to show a bit of a demonstration of the stability of the mandibular denture. So position, quite stable. Even when she was speaking, it wasn't intact on her ridge, considering she did have a minimal or none no ridge to basically work with. And then moving on to the next slide, I just want to show what the patient herself said. She was nice. Take two, because she forgot to mention one of our supervisors, but that's alright. So this was the dental school when I was there. Now they finished it. Promising. So I can tell you guys that the patient smiles everything. We have to cater for different types of patients, no matter what they say. Sometimes, or most definitely, we must be right. Sometimes they think they're right, so we have to listen to them. Attitude expectation, we have to lower it. There's different types of patients, different treatments, so we have to listen to them. We're professionals, and at the end of the day, we just have to do everything step by step. Do our best and try not skip any phase, because end of the day it is us and them. We'll do our best, and end of the day we can only do our best. There will be a few complicated cases, especially with the patients, but they have to be informed from the start till the end of the treatment, just so the expectations are lowered. So a little bit of acknowledgement just with the NZIDT giving me the opportunity to have been presented the case at the conference and to have won the award for it back in 2018. The team at the dental school, and obviously our clinical supervisor John Arson Paul Pierce, our clinical partner Jivan, and obviously the patient Mrs. I hadn't done this in about 2 years now, so just thought I'll just share this with you guys, and hopefully you can take a few notes from this and learn, and we can just share our knowledge together with each other. Thanks again.